priorities. So we'll go over the different frameworks. We'll breeze through them. Let's try and start covering this. I know somebody was asking about a lunch. We'll probably take like a 15 soon after this, but we want to have a full-on lunch. We need to get through all these chapters. And we only have today. We lost yesterday, so it'll be quick. So airway, breathing, circulation is a priority framework, like you said. Right, so airway, make sure that there's no obstruction, it's patent, right, it's open. If not, you can position them so that the airway becomes open. Second is if they're breathing. Third, circulation, cardiac output, right, something's compromised. So make sure that you see for these three, and if not, then move on to the next prioritization. Safety versus risk reduction. So, second, the way that I can explain this kind of ties into the least restrictive, least invasive. Basically, we're going to do the best option with having the least amount of invasion of them. The best way to say this one is, they'll give it right here, is to get out of bed, right? Clients were at risk for falls. So it says select interventions that maintain client safety while posing the least amount of restrictions to the client. For example, a client who has a high fall risk index is getting out of bed without assistance. Move them closer to the nurse's work area rather than choosing to apply restraints, including like bed alarms. I've seen that question be popped up, that what do you do first? And it's always, it's move them to the nurse's station, or right in front, okay? Before a bed alarm, before putting up the side rails. If you put up 4 side rails, by the way, it's a form of restriction. So make sure that you again do the least restrictive, right, versus and the least invasive. We're trying to do the most good without being invasive. Okay, acute versus chronic are also known as urgent versus non-urgent, stable versus unstable. I gave you quite a few examples of this with the heart failure and coming out of surgery, asthma versus COPD. Right, so understanding the disease and how quickly it can progress, you should know this. A good way to know this is, by the way, if you read your ATI, right, at the bottom of the disease, there's a part called complications. Like what can go wrong, right? And those are the acute problems that are going to take more important than the disease itself. So for example, hip arthroplasty, right, they're getting into surgery, all right. They start having chest pain, TPA, right? Difficulty breathing, oxygen saturation dropping. What's probable?
Fat embolism.
Fat embolism, right? So it's more severe. Now we're indicating a very severe crisis problem right now, rather than, again, COPD, oxygen side 90, he says he feels short of breath. Of course he does, right? Like his lungs are not operating well over the course of years. So that's what they want you to do. What's the severe? And if you notice, for all complications, there's always what it says, monitor for, or tell the patient to report X. That's your expected finding, what you're looking for. It indicates a more severe problem. Okay? So those are the ways that I would, again, help you to decide on which patient to see first. Those questions are not uncommon. If you want additional help to practice these questions, in your ATI under, they put it now, I think under should still be under Learn. There will be a module called Nurse Logic. You may have completed this as part of your previous homework. You may redo it. There is one called Clinical Judgment and Priority Setting Frameworks. These two will help you in being able to have practice questions for how to assess or which patient to prioritize first, if you want practice questions. It's called Nurse Logic, and it'll be Priority Setting and Clinical Judgment. And reading, not just doing the practice questions, look at the chapter, it gives like the module, it's like a video. It goes over, it gives you various examples, and those examples are good in you being able, for the future, assess the patient. Okay? I always tell people, because it's like, where did they get this from? ATI if you skipped over the modules on your homework, all right, it's not unbeknownst to me, like, right? You run the time, you complete the test, you fail the test, you redo it in 30 seconds because you know the answers and you scored all 5 or 10 of them correctly. Full points for your homework. If you're doing that, it's not gonna help. You didn't look at the module, you didn't listen to it, and you didn't even do the question. You just answered it. So there's zero help gained from it, okay? So if those are the cases, redo some of these, rewatch some of these modules, they're very helpful in being able to understand the disorders or the priority settings now, okay? Time management. I need y'all to look at the table. All it says right is like, this is some great advice from the book. Use time-saving strategies, avoid time wasting. Like, that's obvious, right? We wanna make sure that we have good versus poor time management. Now, more importantly, look at these time management examples. On my quiz and or their test, you'll see that they'll give you examples of this, and sometimes they're like, select all that applies. They're like, the nurse is gonna like attend to the patient or blah, 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 getting their day started. What should they do or not do, right? Like, what should they do to set up to save them time? Or it'll say that you're observing a new nurse or a CNA, and that what should you correct them, like what should you like call them out on that they're doing that's wasting time? Or it'll say what should you tell them to do to save time? And it'll be these actions, either word by word or in some shape, way, or form saying this. So 1, time savers. You document your interventions as soon as possible after completing. Not at the end of the day or at the midpoint of your shift or whatever. So document right now, right? Gave your meds, gave meds to patient A, gave meds to patient B after you do it. Grouping activities that are to be performed on the same client or in close proximity to prevent unnecessary walking. So if I'm gonna go give medications to, bed A in room 1 and bed B and C are there, I should just prepare, right? Or I can have everything needed to do that in that room. Rather than going to give his meds, now I'm going back, I'm gonna grab my card again, and then, right, oh, I forgot my dressing, I gotta go back and grab the dressing for C. Like, you're wasting too much time walking back and forth with supplies. You could have just gotten all your supplies from the beginning. Estimating how long each activity will take and plan accordingly. So the way that they say that one too is, you like see all your interventions, your tasks, you're gonna write them down and like basically plan them out for the day. Mentally envision the procedure and gather everything. Take time to plan out your care. Delegate activities to other staff, and we will talk about delegating right now. What can you give to your CNA? What can you give to your RN? Enlisting the aid of staff when you need help. Completing more difficult tasks when the energy level is high rather than towards the end. Avoid interruptions by graciously but assertively saying no to unreasonable or poorly timed requests for help. In the middle of MedPass, can you feed my patient? No, not right now. I can finish MedPass and then help you, right? Like, being able to give structure to your day. No, I'm not gonna do that. Or that's not my job, right? Like, I can help you after X. Let me finish here. I gotta do this. Setting a realistic standard for completing these. Completing one task before beginning another. Using an organizational sheet, and then it says using your breaks to socialize with staff. I've seen that they don't, right? You're not talking during the shift, you're talking on your break or your time off. Time wasters, it's basically the opposite, right? You document at the end of the shift instead of after the task. Make repeated trips. You're reluctant to delegate, like you don't spread your work out or ask for help. Starting several tasks instead of finishing one at a time. You're providing care and doing stuff without a plan. You're just going from task to task to task, and you're gonna get things done. It's gonna all gather up to waste more time than not, because you're gonna keep on getting pulled in different directions. Nothing's gonna get done to the beginning. If you're not done with wound care, you're not done with MedPass, you haven't documented at all, you're just gonna be pulled in different directions. Now the problem with management, this Proctor, is that the book is really small. For pharm, med-surg, mental health, they're very specific to what you do. Like, these are the actions, right? A schizophrenic is pacing, do this, right? You administer a beta blocker, watch out for these. Like, it's very specific, right? Heart rate, blood pressure, rise slowly, like it's specific. But in management, the questions are open to interpretation and it makes it difficult. I don't know what's out there. So it's your job to try to take these, like, well, I know what saves time and I know what wastes time. And whatever scenario they give you, you have to interpret these guidelines. Does that make sense? Like in documenting so however they phrase it, there's no like that's something that you need to do. That's the best advice I can give you for preparing for the problem. Assigning, delegating, and supervising. So again, that table, the do's and don'ts, you should be familiar with them for time saving and wasting. Assigning and delegating. The important here thing is I want to point out for room assignments, where it says making client room assignments. Private rooms are for clients who have infectious diseases that require airborne or other protective equipment. Private rooms are preferred for clients who are on drug or contact. These clients can cohort if no private rooms are available if the following are true. The clients have the same active infection with the same microorganism. Okay? So while two people can have, right, like a cough, is it the same organism? Okay, so you have to make sure that they specify they both have the same organism. If not, they cannot room together. Okay? The clients remain at least 3 feet away from each other regardless of the same infection, and the clients have no other existing infection. A private room is also preferred for people who are agitated, have dementia, right, are at risk for sensory overload, okay, or they require privacy for those who are near death. The biggest one here is do not put people with different infection in the same room. Same infection. I'm going to emphasize that for you. Delegating and supervision. RNs and they call them here PNs, that's what they're referring to an LVN, and AP is what you know as a CNA, right? So you can delegate in the sense that you give the correct task to the correct person. They'll say, right, you have the 5 rights of delegation: right task, right circumstance, the right person, right direction and communication, supervision, evaluation. So what they like to see on your question or your answer is the right task. Hey, monitor the input and output. Right circumstance. This means usually, especially if you're giving it to a CNA, the patient cannot be in an acute condition. They cannot be unstable. They have to be a stable patient to begin with. You cannot give an unstable patient to CNA. You can, however, give it to a RN. Right person, CNA, LVN, RN. Direction and communication. Check the input and output every 2 hours, right? This is direct, because check input and output for the day, right now, for lunch. There's no communication. So to say right direction and communication. Check the input and output every 4 hours. Tell me if they have an output greater than 500. Right? Right direction and communication, specific. Supervision evaluation. 4th hour, you check if it's documented. Did they check? Did they do it? You saw that they're doing it. You evaluated it. Because if not, they might be doing it and you don't even know. You might be doing it wrong. So they like to see all 5 elements present. And the way that they like to phrase the question is, again, like how should you phrase it? And then they'll give you like slots or things to like put together or answers of what does that look like. I like to see this table. It says what you can delegate to a PN or an LVN and what you can delegate to an AP. So LVNs, monitoring findings as input to the RN's ongoing assessment. This translates to, if you ever see, you will do an initial assessment, right? Like the first one, okay? You cannot do that. However, if they say that you're gonna assess the patient because you're gathering data or data collection, that's okay. You can do that, but you cannot do the initial assessment, okay? Reinforcing client teaching on a standard care plan. Another key thing. The LVN is reinforcing how to self-inject insulin at home. That's okay. A patient just got diagnosed with diabetes, and we're gonna teach them how to use insulin at home. The initial teaching has to be done by the RN. Okay, so difference between reinforcing teaching versus teaching. Difference between monitoring the finding, data collecting over initial assessment. Perform tracheostomy care, that's fine, right? You can clean them, suction them, right? Replace the dressings, that's okay. Checking NG tube patency, right? So you're checking to see if it's clear or not. Giving them G2 feeding, administering enteral feeding, inserting a urinary catheter, administering medication, excluding IV in some states, and we are that state. Okay? Anything that you see here, the AP cannot do. The only way that I've seen it, that sometimes throw people off, and this has to be clarified, and I hope it's been changed, is they'll say, can the assistant personnel suction the client externally? Like here, if it's externally, like not in the cannula, they can suction outside for secretion, right, or their mouth. So that's what they're referring to. But they cannot suction the cannula. 2AP, activities of daily living. This is all right, you're bathing, grooming, toileting, walking, ambulating, things that we do in their daily life. We can help them with that. Combing their hair and whatnot. Feeding without swallowing precautions. And now I know what you're gonna say, well, in the nursing home, yes, the stroke patients are being fed by the CNA. Okay, but according to the book, if they are dysphagia clients or they recently had a stroke or a swallow or impaired swallowing, the CNA cannot feed them. The LVN or RN must. Positioning, routine tasks, bed making, specimen collection. This one gets people. They can collect, right, like fecal samples, blood glucose, they can check it, okay? Urine specimens, and then they can transport the ABG. They don't do the ABG, but they can take it to the lab. And I'll always tell you, when they tell you like what should they do first, and there's an ABG to the lab, they have to take the ABG first. Okay, you have to take it to the lab. Because the more time passes, the least accurate it will be, or invalid. So you have to take the ABG specimen straight to the person.
You want the paper?
Yes. Okay. So you have to be able to take it immediately. Okay. Intake and output. They can monitor this. Vital signs, and I want that to stay there in parentheses. For stable clients. I'll give you a few examples of people who cannot. If they are one, right, if they have had a craniotomy, so open hand surgery, or open heart surgery, okay? They cannot care for them. They're not valid if they've had a surgical procedure and it implies in the stem they have multiple tubings and drains and or are confused, like they're moving around a lot. They're not good candidates for them because the patient requires a higher level of care, things that they cannot do with them. If they are one day, like the first day post-op, they should not be doing anything with them about walking them, bathing them, like all of that, taking vitals. They shouldn't do that for the first day post-op until after they're stable after the first day. Make sense? So these are little key factors to take into account for your prioritization and who to delegate or give the task to. Another thing is people talk about the blood glucose and they get it wrong. They can take the blood glucose, they can take their vital signs. What they can't do, and the key word there is, they cannot interpret the values. And we see it all the time right now. Take the blood pressure, right? Oh, your blood pressure high, mamas, right? They can't do that. Right? They can't do that. They're not supposed to tell them if it's high or low. They can show them the number, the patient has the right to this, right? What's my blood pressure? Here you go. Right? Is that good or bad? I'll call your nurse. Right? They cannot interpret a high, low, or give information in regards to. They're not supposed to. You see it all the time, but you're not supposed to. Same with the blood sugar. Make sense? Okay? They can take the blood sugar reading, they cannot interpret the value. They can't give information on it. Yes, it's really high. Yes, it's dangerous. Here, drink this with sugar, right? They can't give guidance or interpret the value. So that's the key thing that you should watch out for in the question. Understood? Yes.
What about Call of Duty,
I believe they can switch the bag, but they cannot do the initial one. I'll double check for you, because I've heard that before and I forgot to check. And they cannot do anything with the stoma. Sorry, they can't switch the dressing, but they can empty it. That's what it was, okay? They can drain it, they can empty it, but they cannot switch the bag. Okay, they cannot like do the dressing. Yes?
There is one question on dynamic closing that said, well, two. One was you can't do a dressing change, you can't delegate to AP, but then the other one, the answer was you can't delegate a
Okay.
simple dressing.
I'll say, simple dressings, this implies things for abrasions or ulcers, like the cubitus one. But if the dressing implies a surgical dressing, like that it's a post-surgical dressing, they can't. So, play it by ear, and those really suck, because I've heard that be done a couple times. By simple dressing, the guideline that I would say is, if it's like, again, like an ulcer, an abrasion, right, like decubitus, meaning like a pressure injury, that's fine, they can switch out the dressing. But if it requires like wound care, that they're like applying ointment, it's a surgical wound, they shouldn't be switching. Okay, PICC line dressings, absolutely not, as well. You'll delegate that to the RN. A PICC line is a central line. Yes?
They discharge all
No. I don't know about other states, but not here. Yes. Hence it was on here, right, the folding. Have you seen it be done? Yeah. I mean, it doesn't take much, right, it's just like,
Yeah, I thought that.
right? You can just, and if it is an ATI and things like that, again, remember that ATI is national. So in some states, you can. And this is where it's confusing, and if you work in other states, it'll be weird. Because never will you see it here in California that CNAs do what? Blood glucose. In other states, normal.
Or us giving IV meds.
Or us giving IV meds or starting them, but in others, they're right, more versatile. So it varies by state, so state to your state. Yes? And that's why this test can be a little hard, because it's general, it's vague, because their book can't be specific. It should be more specific here, like check blood glucose. That's not specific to us, it's specific to another state. But that's why it just says specimen collection, what you can collect here. Yes? I don't know about pushing meds to IVs. Do you know which state?
I know New York, and just because I worked with a nurse at a clinical, he told me.
So yeah, it'll vary, but generally, I would say as a rule of thumb, here, you can start the IV line, a peripheral, and you can, administer, normal saline, NS, or an isotonic fluid, not hyper or hypotonic fluids.
Is that even after you get IV certification?
Depends on the place. I would say you're not gonna be like found guilty of it if you don't have your IV certificate. Nobody's gonna be like, oh my God. But, it helps if you do.
No, I meant like that's all we can do even after this?
Oh, yeah. Start the line, I believe you can discontinue the peripheral IV, and you can start the normal saline. You can't administer anything else. This helps out because, for example, in hospice, nothing is given to them other than normal saline. So it works out in their favor where LVNs can hydrate the patient. Okay? Yes? And delegation is one of the most difficult ones. Practice questions help for your do's and don'ts, but I try to give you the best, like, overall of what not to do, what to do. Okay? Vital signs for stable clients, we said intake and output, specimen collections, bed making. Let's see if there's anything else. I told you the difference of suctioning, difference of vitals, interpreting, initial teachings, our data collection or monitor the finding, we don't initial assess. I think that's about it. So, with that, these are vague. Please take your time and analyze the question as to what's it asking for you. I hate that I can't be as more specific, because again, I don't know their specific question. Okay? If you do find problems with the dynamic quizzing, I always tell people, please, if you do see that question and it's funky, like it's not relating to what the book says, screenshot it and let me know where, like what topic it is, like how'd you find it, then we send it to ATI for their quality control. Good? Alright. Alright, so then it goes over the certain scenarios. Feel free to read these over on your own, right? So for example, right task, client has pneumonia, you use a bedpan, nebulizer treatment, right, medication to a pneumonia patient, that's a no. Circumstance, post-operative and stable, that's okay, the post-op, but the question, or whatever it indicates to you and you know the patient is stable, that's okay. Post-op, and they received naloxone to relieve respiratory depression, that means the anesthesia or their sedative was too strong. And now we have something to reverse it. This patient is not stable, right? They're being under watch of what you're giving. Right person, PN, to give enteral feedings to a client with a head injury, that's good. AP for enteral feedings, no, right? Can't give G2 feedings. Right direction, communication, right? Like I said, assist the client in room 312 with the shower before 9 a.m. and notify me when complete. See, very direct communication. Give 312 morning hygiene. That could be a number of things. I help them brush his teeth, we groom them, we wash his face, like what do you want and by when? Okay? Supervision and delegation, again, tell them to ambulate the client. You saw them, safe ambulation, okay, right? You told them some feedback after. 2, you told them to ambulate them and you never saw or witnessed or checked out how they ambulated the client. You good? All right. We're gonna go down to the 5 stages of nursing ability is what I mentioned to you now. Novice, advanced, competent, proficient, right? How you're improving your nursing overall. I think the next one is audits. Yeah, here it is, audits. I want you to just know the types of audits. Okay? You see where it says timing of audits? This is where I want you to understand. Because they'll ask that they're doing X action to gather material. Nursing, quality managers, whatever came, they're gonna gather information based on patients who have been discharged. What kind of audit are they running? Okay, so they'll give you a scenario or how you're gathering the information, and then they'll ask you the kind of audit that they're performing, or vice versa. They'll tell you the type of audit, and you gotta say the action that matches that kind of audit. So, an audit, basically, right, is they're gonna gather information, check that everything's in place, being done correctly, or what are the outcomes. So, in a retrospective cut, the audit occurs after the client receives care. So again, we've given care to X amount of patients this year. Everybody who has a Foley, how many of them got infections and why? How often did we perform care? How often did we flush? How often did we this? You're gathering information after the matter. We already did the care, everything's done. Let's look back and see, did we flush every shift? Did we let them sit longer than a month? Did we, right, what did we do? Concurrent audits while they're receiving care. All right, everybody who currently has the Foley, make sure that we're gonna do X, Y, Z, and we're gonna measure the outcomes as we're doing this, right? We're flushing every day, we're flushing every 8 hours, right? We're turning patients every 2 hours, like what's happening right now. And a prospective audit will predict how future client care will be affected by the current level of services. Well, right now, CNAs do rounds every 3 hours. I think that this is gonna lead to more pressure injuries. We should do X. And so we monitor what will happen in our prediction based on the current level of care being administered. So, what has happened, currently happening, what will happen in 3 different types of audits. Make sense? Okay. Conflict resolution. So the stages of conflict are good for you to know. The way that they ask those questions is straightforward. XX thing is going on. What stage of the conflict they're on, so please be familiar with it. I think more importantly is the problem solving. And you'll see that there's different strategies. Where it says example on page 60. Oh, 16, yeah. You see example? Be familiar with the strategies of negotiating. Avoiding withdrawing, like what it sounds like. Both parties know there's a conflict, we're ignoring it. Smoothing, one party will attempt to smooth the other. Often used to maintain a peaceful work environment, and you just kind of tell them what they want to hear, right?